Today is October 13th, 2020. My name is Dana Yarrick. I'm interviewing Mireya Vera for the Latino Oral History Project, Voces of a Pandemic project at the Center for Latino and Latin American Studies at Northern Illinois University. This project is in partnership with the Voces Oral History Center at the University of Texas at Austin. Please know, Ms. Vera, that this interview will be placed in the Northern Illinois University libraries and shared with the Voces Oral History Center at the University of Texas at Austin. If there is anything you do not wish to answer or talk about, I will honor your wishes. Also, if there is something you want to talk about, please bring it up and we'll talk about it. Because we are not conducting this interview in person, I need to record you consenting. So I'll ask you a series of 6 questions. Please say yes, I agree, or no, I do not agree after each one. There are several questions we need to make sure you agree to before we go on. The Center for Latino and Latin American Studies wishes to archive your interview along with any other photographs or other documentation at the Northern Illinois University libraries. Northern Illinois University libraries will retain copyright of the interview and any other materials you donate to the Center for Latino and Latin American Studies at Northern Illinois University. Question number 1. Do you give the Center for Latino and Latin American Studies consent to archive your interview and your materials at the Northern Illinois University libraries?
Yes, I agree.
Do you grant Northern Illinois University libraries right, title, and interest in copyright over the interview and any materials you provide?
Yes, I agree.
Do you agree to allow Northern Illinois University libraries to post this interview on the internet where it may be viewed by people around the world?
Yes, I agree.
Do you grant the Center for Latino and Latin American Studies consent to share your interview and your materials with the Voces Oral History Center at the University of Texas at Austin for inclusion in the Voces of a Pandemic Oral History mini project, which will include posting the interview on the internet?
Yes, I agree.
We have many questions in a pre-interview form that we have already filled out. We use that information from the pre-interview form to help in research. The entire form is kept in a secure Voces server at the University of Texas at Austin. Before Voces sends it to the Benson Library and NIU libraries, we would have stripped out any contact information for yourself or family members, so that will not be part of your public file. Your public file will only be accessible at the Benson Library and NIU libraries. Question 5, do you wish for us to share the rest of your pre-interview and your public file available to researchers at the Benson and NIU libraries?
I'm not sure about that one. You explain a little more. So if I make that pre-interview available, that's private information, isn't it?
That will only be available to researchers at those libraries. It won't be part of your public interview.
Okay, then I agree.
And finally, on occasion, the Center for Latino and Latin American Studies and Voces receive requests from journalists who wish to contact our interview subjects. We only deal with legitimate news outlets. Do you give consent for us to share your phone numbers or your email with journalists?
No, I'm not comfortable with that one. So what is the standard here? Yes, most people agree, or I don't know, I get comfortable with journalists.
Nobody's disagreed yet for me, but it's up to you. If you're not comfortable with that, that's fine.
That's fine. I agree.
Okay. So that's that out of the way. So tell me a little bit about yourself, where you grew up and your family background.
My mom and dad arrived into Chicago maybe when she was about 8 months pregnant with me. I was born here in Chicago in Grant Hospital and lived in, California, and right across the street from Douglas Park for a few years. And then as a kindergarten and first grader, lived on 26th and Kedzie. I went to McCormick School as my first school, where I didn't speak English at the time. So I got my first reality check of what it's like to be in a school system where you don't speak the language. And that whole learning process, my mother said, was interesting, how I evolved from becoming a Spanish speaker into an English speaker. But by the time I was in first grade, she said I was pretty dominant. Not dominant, but I could navigate both languages, in English and Spanish. And so I remember really the main part of my upbringing was in Brighton Park. I'm going to Davis Grammar School and Kelly High School, where, I really learned quickly about social justice and, the differences between being Latina and the majority white students, right? And, also being very rooted into our Mexican roots. Every summer, we would do a trip to Mexico and spend the summer there with family. So I became very familiar with our culture at the basic root level. And we also, my aunt had a ranch far away from the city where, the basic necessities of running water didn't exist. So you'd have to go out to the pila and bring in water every day. And the corn you had to, do in the metate in order to get tortillas. And, very, very basic kind of stuff. The animals or the whatever little meat we did have was from the animals on the farm, but most of it was an orchard of apples and peaches. And so it was quite nice being able to eat fresh fruits when I was young. And learned a lot about my history, about Mexican history. So that's something that I am very proud of and carried closely with me, so that when I came to, doing some important history pieces in grammar school, particularly the Texas War and then the Mexican-American War, how I read about it and saw it from the museums and the history books over there in Mexico was very different. And it made me aware of how skewed the history books were. I didn't realize that, of course. I was very trusting up until then. Getting was true, but skewed, and there was a lot of our own history missing from there in terms of our history as Latinos here in this country. So, I very quickly, as a young grammar school student, learned that there was a difference in how things were delivered, and in acknowledging us as contributors to the society. And very young, decided I wanted to be a teacher. And shortly after that, the bilingual education movement started. So that's when I became interested in becoming a bilingual ed student. So this was in the 70s already, and bilingual education was taking off. And I was very fortunate where I had family members who were leading the bilingual ed program here in Chicago. I was in high school at the time. And one of those was my aunt, Micaelina Salinas, who was part of that University of Illinois movement to create the Teacher Corps program. And so they were seeking teachers from Mexico. And my mother was a teacher de la Normal Superior of Mexico, which is the academic institution that gives you the teaching degrees, that graduates teachers. And so she was able to get into that, and it was very impressive to see my mother, who was limited English speaking, spoke some English, go back to college here in order to get her degree revalidated and become a teacher in this country, a bilingual ed teacher. And I was very fortunate at that time that in 1974 at the University of Illinois in Champaign-Urbana, the bilingual ed program started there. So I immediately, when it wasn't as difficult as it is in today's world to sign up for colleges. You didn't make 101 applications. You applied to one school and hoped it would go well. That was it. And so I was very fortunate. And one of the things I do, probably high school was the toughest period for me in terms of becoming proud of my identity, but also getting pushed back because of my identity. I mean, teachers didn't expect for a Latina to be smart. So there was that constant move of, well, you're only going to be, a factory worker, or you're going to end up getting married, or, never that encouragement to do well. But since I was in 7th and 8th grade, I had honors classes. So when I started high school, I was put directly into these honors programs. And back then there were no AP either. I had some challenges with some teachers who didn't believe in my ability to do honors work. I had a counselor when I told her that I wanted to apply to school, college, university. This particular counselor said to me, why would I want to do that? She said, why? You don't need to apply to college. Why would you want to do that? People of your kind either get married or become a secretary. And I said, well, I don't want to get married or become anyone's secretary. I want to go to the university. I want to go to a college. And she was resistant and reluctant, but eventually started helping me in some kind of way. And I just said, I'm going to go to college. Watch me. So you know that the majority of her folks don't go to college, and if they do, they don't make it. I said, well, it'll be different for me. Watch me. And I was less than, I don't know, there might have been 100 Latino students in that school, and maybe 2 of us went to college. There was really no encouragement or pushing you forward, and so I learned very early on that needed to change, that system of inequity was wrong at every level. And it was almost a how dare you attitude. Tell me that because I'm Latina, I'm not as smart as you, or I can't make it because I'm not the same color as you. So that really sparked a fire under me, and I decided to become a secondary education high school teacher, but majoring in history, because again, that history, that from being in El Castillo de Chapultepec and watching Los Niños Héroes, kind of plunging one of them and wrapped in the flag to his death, not wanting to give up his country, and then read the history books of how, General Scott or whoever he was marching on Chapultepec just took over, never mentioning how they killed 5 children, right? Military children, but they were all young. They were all under 16. So at any rate, that, along with, my desire to learn about the conquest of Mexico and all that got me into making history my major. And then in college, I ran into a whole lot of other set of issues there. And I saw, I didn't realize it in the beginning. There's 40,000 students in the University of Illinois, right? And there were only 30 of us. early Latinos from freshmen to seniors, you know. It's like, wow, you know, in the beginning it doesn't hit you, but as time goes on, you're like, wow, we really are a small group here. And then, of course, you go to, you know, you're always trying to do best in your classes, and somebody says, oh, yeah, I know somebody who speaks Spanish. She cleans our house. I'm like, oh, really? That's nice. I don't clean houses, you know. But um, so, you know, those experiences really just even enlighten more the idea that there was so much inequity academically, even at the university level. I was very fortunate at the time I got into University of Illinois. There was a huge movement of Latino students that had already started moving towards, you know what, this isn't right. We need more resources. You need to do more to bring in and recruit Latino students. So I immediately got into that bandwagon. And it was the first year La Casa Cultural Latina opened up, which was, you know, a big, not a big win, but it was a win that the prior generations had fought for to have, you know, to help Latino students, a few that were there to really, you know, provide support and come together and get through college, you know, go from point A to point B. Um, and, and so that was a very huge learning experience for me as well. You know, so I don't know how far you want me to go on to this, but that's basically my basic upbringing, if you will, that just really got me fired up, aware, conscious of, you know, the not only the academic inequities, the social inequities, you know, the injustices, you know. I don't know how many times I was called a spica's little girl. At the beginning, I didn't know what that was. And once you do, you start fighting back. And, you know, it's just, it really just, it blows my mind away that we would be looked at differently just because of the color of our skin, our language.
Where in Mexico was your family from?
Well, my mom was from Saltillo, Coahuila, the northern part. And my dad was from Toluca and primarily lived in Mexico City. However, when he was working, excuse me, in Reynosa, my mother had just started teaching. She had been teaching there her first year as a grammar school teacher in Reynosa, and that's where they met. But you know, they lived all their lives in Mexico only until they came here in 1956.
And your career path led you to medical interpreting services. I wonder if you could talk a little bit about how that came about.
It did. That was real interesting. So I was a teacher, bilingual ed history teacher, and I loved what I was doing. I was at Juarez High School for a little bit as a student teacher, and then that following year, a middle school. Yeah, I really didn't want to be, to be honest. But my passion was history. My passion was, you know, talking to high school students, and I just felt like I didn't realize it then as much as I do now. That was the point that I needed to be to encourage them to go on to college, to get them to thinking about going out, to making higher education an option, okay? Because while I was going up, it didn't seem to be an option. So when I was in this middle school, Benito Juarez High School called me back to become a teacher, be a position there, and my principal wouldn't be. I was not happy about that. Um, and it was at that point that I decided to leave education because they were, you know, dictating which way you should be teaching. And I, as a teacher, obviously needed a bilingual ed teacher, and it was very heartbreaking. Students were at third and fourth grade reading level, and I had eighth grade students. And you know, the other piece to that was I wasn't really prepared to do the reading, the writing, and the math kind of thing. My focus was history. And all I did was throw down a curriculum book and said, here, follow this curriculum and you'll do fine. And of course, being the self-motivated person I've always been, I did. But it set up a bad precedence for me in what I really wanted to do. So at that point, was married, moved to Mexico for a few years, came back with experience in a Lamaze program of just teaching mothers to get through pregnancy with Lamaze. And there was an opportunity in a hospital to teach to teach patients in Spanish. I wasn't doing prenatal care. I was more the non-clinician side of this Lamaze program because I was a nurse. And then when they hired me to be a patient representative, to check in on patients, to see, what their needs or issues are, and any way we can make their stay a little bit not as difficult, considering health is health, and when you're not doing well, it's hard to be in a hospital, right? So the concept of patient representation was a very new one in the Chicagoland area, but it was taking off among hospitals. And so I was fortunate to be hired to do this. And I really concentrated so much on the Spanish-speaking patient. I concentrated on everyone, but the Spanish-speaking patient, again, like the Latino student, was off of everybody's radar screen. And I quickly saw how the communication process between them and the doctors was not the most efficient. Things were getting missed. And the only one coming out on the short end of the stick was the patient and her family. I witnessed many different situations that just broke my heart because the family didn't understand what was being said. So I quickly got involved in making sure I was the voice of the patient and working with patients closely and the physician side to make sure that the communication was where it needed to be. But I knew nothing about medical interpreting. I knew nothing about the formalities or that this was even a career option, if you will. And after a few years of being at Mount Sinai Hospital, I also became very active in the community, American Cancer Society, MALDEF. There were several different boards that I was privileged to sit on and to be a part of. And so starting to hear that this wasn't just unique to Chicago, but something across the country really caught my attention. And shortly thereafter, a task force was created. An Immigrant and Refugee Health Task Force was called. And so when all of us, many providers from the Chicagoland and outside Chicagoland area came together, we suddenly were talking about the very same issues. What were the issues that kept immigrants and refugees from getting quality health care? And over again, it was language. So it wasn't just access to insurance. It was all of that, the access, the affordability, the uninsured versus the underinsured. All of those pieces were critical. But at the end, even if they could get in, the language barrier was huge. And we discovered there was a program in Minnesota that had started to develop, and one in Seattle. So we started working with those experts that had developed a medical interpreting program, had even gone to Europe to get training. It was more than the terminology. It was, how do you create a two-way conversation when three people are there, when you have a triadic relationship, right? And it caught me and took me, because this was something I was so passionate about. I mean, the biggest reason I was a bilingual ed teacher was to help students maintain their intellectual and academic level while easing into this country, but still being able to fill their full potential. And that to me has always been the heartbreaking piece of that language barriers, if not addressed, limit you from reaching your potential if you don't have the right tools and resources. So here we are again in healthcare. What healthcare is about, you know, getting to a point where you're feeling well. And with the language barrier, you know, you may go home and take the wrong medicine or take it the wrong way. I remember one time walking through the emergency room and hearing a doctor talking to a patient through the sun. And this was one of those most common things I found, children being used as interpreters. And so the doctor was saying, I guess the father had an injury on the hand. And so he said, okay, he must take this medicine once a day, every day for 7 days. And I heard the boy repeat to the father, Papi, and I'll say this in English, Papi, the doctor says you have to take this medicine 7 times a day for the next week. I one time had a patient come up to me and said, you know, I heard you speak Spanish, you're the patient rep. You know, I came to the emergency room about a month ago, but I'm not growing. I'm pregnant. I'm 6 months pregnant. And I feel like my baby's not growing. So I want to see a doctor. I said, well, when were you in the emergency room? I looked into that, and it turned out she had had a miscarriage and didn't understand. And so having left the hospital not knowing that she had had a miscarriage, and then, you know, a month later wondering why her baby's not growing, that was one of those shocking moments for me. And I have so many situations that I could talk of when, you know, you're not using interpreters. I had a doctor tell me, you know, this patient is brain dead. We really need to tell the family that, you know, this is the third and final test. And they, you know, back in the day, this was way back before the 90s, it was a 3-series test, and that third one would determine, you know, confirm with finality if the patient was brain dead or not. And this doctor started to explain to the family, through me as the interpreter, that the patient was brain dead. And so after, you know, 5 or 6 minutes, then the patient's family member started asking if this particular patient would ever walk or talk again. So I knew at that moment that they didn't understand what brain dead meant. Now, as an interpreter, you cannot explain what's not being said. So even though I knew the definition of brain dead, I wasn't going to define it for them if the doctor's not defining it, right? And so that impression gave me that that response, those questions, told me that the family members did not understand what brain dead meant or the condition of their family member. So I turned to the doctor, I said, I don't think you understand what brain dead means. Did you use an interpreter to talk to them before? Oh yeah, we've had an interpreter, you know, with all of our conversations with them. I said, okay, who's the interpreter? And they pointed to an 11-year-old girl, young girl, standing there. And I went, wow, okay. I said, well, I think we're going to need to start all over again, because I'm not sure they understood the meaning of brain death. So the doctor started explaining, and I was interpreting, and within 3 minutes, just the family started crying and crying. But to me, the hardest piece was to watch this young girl who turned white and then just started passing out. And all I could think of was the trauma we were putting this young girl through of having given her family some false hope when she herself, even if she spoke some English or spoke English, couldn't understand the medical terminology or couldn't understand all of what was being said, right? And it was a shame on us moment of why we were putting such a young girl in that kind of a situation. And that was kind of the impetus that had me, then really move forward into the direction of we need trained and qualified medical interpreters. And what does that mean? It's beyond just having, medical terminology. It's also colloquial terminology. We have how many different countries in Latin America, with different colloquialisms of Spanish, right? And then you've got the urban and the rural of each country, north, south, east, west. So, it's not just the medical. It's colloquial, it's local, it's how do you create that two-way conversation, as I was mentioning earlier. Your positioning is key. How you use your tone of voice of the speaker, your fidelity to the message, interrupting when you're not understanding, but not pretending to know what you don't know, which is hard when you're having medical conversations. I had Russian interpreters who one time the Russian interpreter said to me, I can't tell the patient they have cancer because the family doesn't want me to. I said, but if that's what the doctor is telling you, you don't have a choice. So, what this interpreter was saying is the doctor says you're sick and you need to take care of yourself. Instead of saying the doctor says you have stage 4 cancer and we need to get you into radiology. So there was just so much mishap going on. And as good as some hospitals were to try and have interpreters, if you will, not having training behind them was really setting up patients and hospitals and for an array of errors, communication errors or of miscommunications, right? Where the message is not getting across at all, like this woman who didn't know she had a miscarriage. Or one woman who didn't know that she was going to have an anencephalic baby and didn't hear it until her 9th month. And according to the records, she had been told in her 5th month. So, there was just too much of that I just knew was wrong at every level, both for the healthcare settings and for patients and their families. So I was very fortunate to become part of this Travelers and Immigrant AIDS Task Force. We learned about, what other areas were doing about training. We learned that Illinois was 10 years behind Seattle. We said, okay, we have to do something very quickly to get, all of us up to speed. We helped, we helped write this law, like this with former Senator Jesus Chuy Garcia and his chief of staff helped us. We with Linda Coronado, myself, and Wendy Siegel, who was part of the Immigrant and Refugee Health Task Force back then. All of us sat down together to write this law, and we took something that California was writing. They didn't have it quite in place yet, but you just look at what's out there, you do your research, you do your homework, and we did a very basic kind of law, and Governor Ryan at the time, and it was a bipartisan support, which was really good. It was Jesus Chuy Garcia and Judy Bartopika that supported that law. And we had it passed, and Governor Ryan signed it on January 1st, 1994, SB 435. So we were one of the first states, not the first state, but one of the first few handful of states in this country to have a state law that supported having trained and qualified medical interpreters. And it's called the Illinois Language Assistance Services Act. And so, we're proud that we have this law. And, you know, it's had a few little changes here and there, but it's still there, and that's a good thing. So it's really a piggyback to the Office of Civil Rights, Title VI of 1964, you know, that states you cannot be discriminated against because of your religion, your national origin, and so language falls within that. You know, and you can't tell somebody who doesn't speak English to come back with somebody who does, or we can't take care of you because we don't have an interpreter. No, all hospitals, anyone receiving federal funding has to abide by this law, Title VI from 1964. And so the Illinois Language Assistance Services Act was a very nice complement to this law because it even included nursing homes and talked about having posted signs, talks about having posted signs that you offer interpreter services in your lobbies, in your main entrance areas, so that when people who don't speak English or are deaf or hard of hearing, as they come in, can see these signs saying we offer interpreter services. Right? And what we as a group did is we looked at the sign language curriculum and really saw how, you know, the techniques they used to develop that two-way conversation to make sure that the interpreter is only the voice and not the one maintaining the relationship between the patient and the healthcare provider. You have to allow them to develop that relationship. It's the provider that has to be the direct giver of clinical and medical services and conversations. It's not the interpreter. So establishing your role in that conversation almost immediately is key and important. And we learned that from the sign language interpreters. We were very fortunate that we had one sign language interpreter on our task force and on our little steering committee that then created. So I was part of the steering committee. I kind of spearheaded that initiative of getting 4 or 5 people together every 2 weeks in the summer of 1993 to make sure that we had a strong curriculum to support training qualified medical interpreters. When we started out in Truman College, we made it a 3-phase program. Started it with 40 hours, so it wasn't enough, and then expanded it. And then eventually ended up at Daly College, where I was teaching medical interpreting techniques. And that was, I want to say, we started in Truman in 94, and then by 1997, was working at Daly College with my colleague, Linda Coronado. So both of us, held that medical interpreter program for at least 10 years. But that's how I got started in medical interpreting. It was just really being knee deep in it, hands-on, and I've only told you very few stories of the kinds of things I witnessed and lived through that just really took me back to, just something needs to be done. And just, things fell in place. I was very fortunate when this task force came about and, jumped on it right away on that bandwagon. And we've gotten some good work done, but we still have a long way to go. There's no doubt. We have a long way to go still. Okay.
So let's switch over to your experience during the COVID-19 crisis. You're the Director of Interpreter Services for Sinai Health Systems in Chicago, and you work at Holy Cross Hospital?
I work at Holy Cross Hospital as the Community Services Director. And so for Sinai Health System, I'm the System Director for Interpreter Services. So I was hired at Holy Cross 5 years ago to start an interpreter program there. So I started it from ground zero. There was nothing there at the time. And then transitions and changes, they asked me to oversee the interpreter program at Mount Sinai Hospital, which is our North Campus. So Holy Cross is part of the Sinai Health System, And Mount Sinai Hospital, oddly enough, is that first hospital that I worked in healthcare when I first started my career in healthcare. And that's where, at the time that we developed the interpreter training techniques and worked on, we're part of the work group for developing this law. All of that was while I was at Mount Sinai in my first round. And I left in 1999, approximately 2000, and went to Resurrection Healthcare and started an interpreter program there. But then I came back, and it was just interesting because when I left, I had left this interpreter program, one of the first of here in the Chicagoland area. You had County that had a big interpreter program, but very few other hospitals did. Sherman, I think, was another one. So when I left Sinai in the late 90s, there might have been 7, 8 interpreters, Spanish, Russian, and Polish. And I come back, and it's a 24/7 program now. I mean, it's completely evolved. And 24/7, 18 interpreters. It's just, the growth is phenomenal. And you could see patients feeling so much more comfortable. That this is an immigrant user-friendly hospital. Patients, no matter what language, they speak, know that they can come to Sinai Health System and get an interpreter. If not face-to-face, at least through video or telephone. And my first year in having the whole system interpreter program report to me, I found that we had 77 languages we served. 77, all the Sinai Health System. Spanish, obviously, being the biggest one. But it's just amazing how much that program has grown. And I bring up the history because it was a tiny little thing when I left the first time, and so it just goes to show that when the need is there, it's going to grow, and and you're going to get the patients coming to you because they trust you, because you speak their language and you understand them. I'll never forget that that a comment the doctor made to me one time shortly after we started the interpreter program at Mount Sinai in the early 90s. He said to me, I've had this patient for 3 years now. She's been a patient of mine. But now that I have an interpreter to speak with her, I feel like she trusts me. I feel like when she talks to me, she's looking at me and she's talking to me, not to anyone else. And he thanked me so much for the interpreter because it made a difference in his practice and in his relationship and how he was being viewed as a doctor who was providing quality service. But that trust was a big piece. So it's exciting to see the impact it has had at Mount Sinai Hospital and how it's grown to a 24/7 program. And that's one of the very few in the city that are 24/7.
And now during the pandemic, the effects of the family separation that has been necessary during the crisis has really put what you're talking about into bold relief. So I was wondering if you could talk a little bit about the effects of that and how that's played out in your hospitals during the COVID-19.
Because this was a moment where for self-safety or fear of getting the disease, minimizing the spread, interpreters were frightened. And I'm not talking only I'm talking nationwide. So video remote started actively working its way in. I mean, it's been a part of any good interpreter program has multiple tiers of resources, which is face-to-face interpreters, the video remote interpreters, and telephone. So you have different levels and agency, 4 different levels. Resources. And this, of course, made it what seems to be, by those that aren't knee deep in this, what seems to be a good response to an interpreter during a time that COVID is a concern, or a disease like this is a concern of spread, right? But in my heart of hearts, I knew this wasn't going to be the answer because of the need to develop that trust for families from the outside who can no longer come in to see their loved ones, and from the patient themselves inside who's scared to death, not being able to see their family, only being able to talk in moments to them. It was, it was a, and it is a very frightening situation, very frightening. And we know for a fact that we don't have 100% bilingual nurses out there. We just don't. And nor do we have 100% physicians out there that are bilingual. Um, so the need, especially in an area like Chicago, is going to be great to have somebody who knows how to create that conversation between the two parties and to make it clear with the masks on. When a patient is intubated and you've got a video in front of you, how sure are you that what is being said is going to come across clearly and accurately, or that the interpreter is catching each and every one of those words? As you're muffling it through a mouse, you may not hear. I mean, we know what that sound, that muffled sound can do when it's got to get to a device, right? And I'm not saying it's bad. VRI are good in very many situations. But in these critical moments, when human touch is missing, because everyone is protecting themselves, it's even more important than ever to have an interpreter available, a face-to-face interpreter available. And I was very proud and thrilled to see that the vast majority of the interpreters at Sinai, at Mount Sinai, and at Holy Cross all rolled up their sleeves and said, we're scared, we're nervous, and they'd come in and clean everything off 1,000 times, but they stayed. And certainly my plan B was, what if people say, I prefer to be furloughed, or, let me take my vacation time while this passes. In the beginning, we didn't know how long it was going to be, right? I knew I'd have to think of other options, but every one of these interpreters rolled up their sleeves and said, we're nervous, we're scared, we don't like it, but we need to do this. We need to be here for the patients. And I was out there along with them on weekends, interpreting for COVID patients, and just seeing the kinds of situations that could have gone wrong badly and quickly had I not been there, had a live interpreter not been there. And one of them, I remember, was a woman who had just had a stroke. And so imagine with the video, trying to hear what she's saying, as the paralysis has already sunk in. And so now I'm asking her to try and write the words she's saying. And it was, a situation like that really brought home the idea that video remote interpreters just were not going to cut it in these crisis times. They just could not do the job, the accurate and efficient job of not only bringing in the clinical relationships, but of keeping some human dignity. When you're not understanding and you've got people around you in masks and you're scared to death and you can't breathe, I couldn't see it. I couldn't see videos replacing live interpreters for that reason. And I think those live interpreters made a difference in each and every one of those patient experiences. And especially when the families were outside the hospital wanting to come in and being told they couldn't. And one of those times I was walking by the lobby and the patient said, I just want my father to have his phone. That was it. I can get it to him. And you gear up, you do all the PPE and plus some. Those simple things, that videos and phones just can't do, right? And so being able, intervene in these kind of ways. And in this experience with the stroke patient, when the stroke patient wrote out finally a little bit, I could read and catch up on what she was trying to say, catch what she was trying to say. I saw that she was talking about her esposo, her husband. And when I said, su esposo, she's like, sí. And she's indicating, he's on the plane. I said, oh, okay, he's on the plane coming to see you. And she's like, sí, Mexico. So he's coming in from Mexico. And, fortunately, I was there to help out with this conversation with the doctors. And I am so sorry, he won't be able to come in. We had, this was early April. Everything had just shut down. There were no more visitors being allowed in to hospitals for their safety, obviously, and the safety of their own families. And that was so hard. But had she not known, had she not heard it from an interpreter, she wouldn't have been prepared and could have even, suffered more disappointment than what she was going through at that time. So being able, again, to this patient to get a phone to her from her family so that she can try and communicate back and forth. But, it's just those hands-on kind of experiences and moments that you realize it's not only hitting us hard because of COVID itself, and we're those essential workers out there, picking it up at every place. And then we live in smaller quarters sometimes, but we also, have that language barrier. And one particular patient, I remember the caseworker saying, he's ready to be discharged, but with some oxygen. So, he can go home. And so it wasn't until that moment that I was there as the interpreter that the patient was able to say, I can't go home. I can't. I have an older mother who lives with me, and I have a 2-year-old and a newborn. My wife won't let me come home. And I agreed, he agreed. So then again, it was looking for those options of where we could place him until that period, that quarantine period passed, right? But all of those situations, I just wonder, no, I don't even wonder. I know it would have been so much more challenging and harder for the patient, to really deal with the impact this COVID was having on them and their families. And being there live face to face as an interpreter, I really think made a difference. And I applaud all of the medical interpreters that Sinai has, because I was so proud of them. They all rolled up their sleeves and said, yeah, we're scared, but we'll go in. We'll stay here. We'll go in and go to the patient. And they took the necessary precautions, the distance and the PPE and everything else. But it was still never easy. Never easy. But they knew it was the right thing to do. And I knew it was the right thing to do too. And I was fortunate that the vice president supported this decision. Whereas one time it was like, should we do video? And they very quickly supported that and saw the difference.
Are interpreters working with the families as well, communicating to them medical information, etc.?
Yes, during this COVID time, absolutely. We don't unless the patient is in the room, unless the family is in the room with the patient, right? But during this COVID time, because the patient was on the outside, literally, it was a lot of communication back and forth between family and patient. They would be involved in that.
And how did you accomplish that? Was that done through video or?
No, that was on personal cell phones.
Okay.
Personal cell phones connecting to one of our phones. Yeah.
But the family was on the outside and you were communicating with them by telephone.
Well, by cell phone, so sometimes time them so that they could see their loved one in the hospital. And there were a few times that they were calling in to say goodbye to the loved one. And that's hard.
Yeah.
But unfortunately, that's just a sign of the disease, right? The times that nobody can help, but to be there to assist these families in need, and even more so the patient. They, there was a case where an elderly patient no longer had COVID, but was on hospice. And so the family, just for the life of them, could not understand why their mom or their family member was the patient no longer had COVID, right? And so as much as, they didn't use an interpreter at the time, and so the family was having a hard time until one of the interpreters was able to come and explain, along with the nurse and the doctor being there. But it wasn't until that moment that the patient was able to understand, the family member was able to understand that the patient's lungs had been so damaged by COVID that even though the COVID no longer was present, they weren't going to recover from that. And so, again, the patient's impression of something's not right here, or you're not doing a good job, or she's not getting the care she needs. What do you mean you're sending her home? If she still has COVID, no, she doesn't. Well, if she doesn't, why is she dying? So those very critical and delicate conversations, I don't see how they could have been done on phone or video. And as much as you can't go near someone to hug them and to, extend a hand, say, I'm really sorry you're going through this, your body language, your facial expressions is everything. And that they could see and connect your concern for their situation is so important. And that's never a good place to be when you're losing a parent. But the fact that there's somebody to explain it to you in a way you could understand, and not leave angry that somebody didn't do something right, but really understand that everything was done, and this is where it's at right now. It's just so valuable to be able to communicate that to families and to patients that we're trying to reach their family. We're like, no puedo hablar, no puedo hablar, and you could hear them, but they couldn't speak loud. So again, just making sure that you're getting that information across to the family as they want it to be heard by their family. It was this experience was really eye-opening for me. It just, and of course, as I saw the numbers of Latino patients growing, and Latino community members contracting COVID, it brings home stronger the idea that you need to have trained and qualified interpreters there, and angrier that why is our community getting so impacted? It really just opened my eyes. It broke my heart many, many times to see patients and families suffer this way. But I was grateful at the end of the day that one of the interpreters would always be there to help in any way they could to make that difference in that patient's life. So it's something I hope we can one day leave behind, this whole COVID experience for sure. But the value of interpreters is, it's clear to me. It's very clear to me how valuable they are, that they can't be replaced by machines in, critical kinds of situations like this. So.
Well, you're the expert in official translation services. And so I wanted to get your take on this issue. I have interviewed some nurses and CNAs, Latina nurses, and how important it has been for them to be able to speak Spanish to their patients. And that in some cases, given the situation with COVID where families aren't in the room with the patient and it's just very difficult, medical communication becomes very difficult, that they've had to step in and if there wasn't an interpreter there, play the role themselves in that. And sometimes even maybe stepping over the line where they knew, what's supposed to happen is there's supposed to be an official interpreter there to do that kind of thing, but it just wasn't possible. And so they found themselves communicating with the family and with the patient in ways that maybe normally they wouldn't have. Has that become an issue at all in terms of professional interpreter versus frontline, caregivers?
Well, I think that's an ongoing. It has, because rightfully so, those that are bilingual want to be able to contribute or step in when needed. And it's important that in hospital settings that whenever you pair up a patient with a bilingual provider, whether it's an MA, a RN, an LPN, a doctor, a PA, a case manager, if you compare them up to that bilingual provider, it's always going to be a win. Given that bilingual level is what it needs to be medically, okay? Because that's the other thing. We mostly always hire people on their word that they're bilingual, right? And if you grew up speaking Spanish at home, your level of bilingual is going to be different than somebody who grew up in a native country for years and then comes to this country and learns English. So everybody's proficiency level in those two languages, whatever they are, it's going to vary. And for in a medical field, especially when you're dealing with health and wellness, disease and conditions, you want to have a certain level, a high proficiency level in two languages, right? So although ideally it would be great to test anyone who identifies as bilingual to see how bilingual they are, and then to say, yes, you could have patients directly and you can speak in Spanish with them, or no, your Spanish or your English isn't strong enough, so therefore you need to call for a trained and qualified interpreter, because you don't want those mistakes, of calling, you're referring to a gallbladder and the patient's thinking you're talking about the other bladder, so there's so many different kinds of errors that can happen in even the little things. I had a patient one time who got offended that the nurse had told her that she's going to have boogers coming up and down her throat, because the term in Spanish is phlegm, but she used mocos, which is boogers, because that was her level of Spanish, right? Mm-hmm. Phlegma, she used boogers, and the patient was a little bit, what does she mean? And just so there's different levels of that proficiency. Had one time who thought she was bilingual would say, well, anytime the doctor uses me to tell them about a pap test, in Spanish the pap test is Papa Nicolau, right? Pap test. But she would say bacalao in English. Catfish. How big she would, I don't know how many women she ended up telling the doctor was going to give her a catfish test. So those are the little but big things that, the bilingual proficiency is critical, depending on what your station is within the hospital, right? Where you're positioned or Are you at the front desk? Are you in the clinical area? Are you in the non-clinical? So there's all of that. And it's great that when we know that someone is bilingual, that they are paired up. And, you know, we would love to be the Band-Aid solution. But the reality is that there's still not enough proficient bilingual MAs, CNAs, RNs, doctors, and everything. And so you don't want to take a chance on a critical conversation or even on, you know, your pain scale. Where's your pain from 1 to 10? So I always, you know, remind individuals who are bilingual that if, you know, and I even test them orally. We'll talk in Spanish for a little while just to see where they're at. And then that at least gives you some comfort that, okay, you know, they can handle it when, you know, they need to step in. But interpreters are qualified medical interpreters. Most of our Sinai interpreters have received over 200 hours of medical interpreter technique training. Not everyone, but, you know, now with their years of experience, that's what they have. And you can't take away that relationship between the provider and the patient, or the provider and the family. And you really are the voice of these parties. And so it's just too easy to think of, well, her last, you know, she's Mendoza, she's Lopez, she could speak Spanish. Well, no, my last name does not dictate the proficiency of my language. I mean, we even had a president in Mexico whose last name was Fox. Who would have ever thought he was a Spanish speaker, right? So you have to be careful. And it's not that you shouldn't do it, but if you are limited English proficient, or if you are limited Spanish proficient, then it's always better to call for an interpreter.
Is there any example of a process being in place to help the frontline providers, some kind of interaction between the professional interpreters and the frontline providers to help them to be more effective in their interactions with the patients?
Well, we do a training every year with residents to show them, you know, what their role is in creating a team. You know, and so this training is really about, you know, look at the patient, talk to the patient directly. Do not use ask her, tell her. It's speak to them directly. Pretend they speak English. And so the interpreter then can do their job of being your voice. And they position themselves in the right ways in the middle of this conversation. And making sure the clinicians and the providers know that is important. Do we train everybody? Not always, but there's always that reminder. So each and every time an interpreter comes to your bedside, it's okay, you know, please look and speak to the patient. They tell you each and every time, please look and speak to the patient. So there's that constant daily reminder. And we also give patients little cards that say you have a right to an interpreter. So they also have access to the number, to the hotline number, if you will, to ask for a qualified medical interpreter. And all they have to do is show it to the provider when they walk in. So that's the other reminder to nurses and lab techs and anyone else who might need an interpreter that, you know, I don't speak English, but here's a number to call the interpreter. So, you know, we have some reminders in place on a daily basis to do that. Is it foolproof? Well, not always. Sometimes folks feel I can't wait, or let me just do this real quick. And that's where things can potentially go wrong. Or let me grab the CNA, who then the CNA has to say, you know what, I'm running to another patient's room. I'll call the interpreter for you. You know, you don't want to call the interpreter, I'll call the interpreter for you. But it is teamwork. everybody has to be on board with it. And I will tell you, the physicians who use interpreters regularly are believers, and they know that's the only way to have a trusted conversation with your patient that is not going to go wrong. And interpreters also sign in and sign out as the providers do off of their log sheets. So we have a check and balance of who was being used for what patient when and who was the requester of that interpreter service. And so it really is teamwork. And once you've tried it, try it, you like it, you really do. You understand the value add to the medical component here, and just really ensuring the safety of the patient and the wellness of the patient. Because now, and studies have shown this over and over again, how patients receiving interpreter services are also patients that are compliant, which means they take their medicines. They're not repeat patients. They don't come back to the emergency room as much because they get what they need to do once they're home, right? And when you don't have an interpreter at discharge, or somebody that really links that final piece to you're going home now, the incidence of a repeat visit, an unnecessary repeat visit at that, into the emergency room, those numbers go up. So it really is financially to the benefit of the hospital to have a qualified trained interpreter, not just anyone who's bilingual, a qualified trained interpreter within your institution, assisting patients, because it's going to impact your bottom line in a positive way to have them there. The readmissions come down tremendously, and the compliance level goes up. The patients and their medication, and understanding, what they need to do to take care of themselves.
So, Mireya, oops, got a little interference there. You've gone through your own medical situation, and I was wondering if you could talk a little bit about what that's been like in the midst of a pandemic for yourself.
Well, Joan, because it really is. I'm grateful. I've worked in the healthcare system for many years, so I know how to navigate, or at least be my own advocate. But I will say, having the times I've had to get on the phone to talk to the insurances, to talk to the providers, to coordinate things that need to happen for my care, hasn't always been real easy. And I said this to a doctor not too long ago, where I'm just grateful I have some advocacy skills, and that I know enough about the healthcare system to coordinate some of these services. I can't imagine what it would be like for patients who don't have it. That sit back and wait for that phone call, or to sit back and say, well, I'll hear from them in a week or so. And sometimes things have to go boom, 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 boom. These kind of decisions, if your care is going one way versus the other way, you've got to start moving faster. And so I have wonderful, wonderful care, I will say that. But as a patient, I'm just grateful that I have that advocacy experience, because, otherwise my situation might have gone a different way, because it was taking so long in this pandemic, to be seen, because there was a telehealth, and nobody's seeing what's happening to me physically, and those physical changes were what led a doctor that saw me, not because it was an appointment, but because I physically went up to him and said, look, and said, oh my, okay, we need to get you into the emergency room. So that simple telehealth is a wonderful option when it's not serious. But, you know, in my particular case, it was a situation that needed immediate attention. And had I not known what to do to get that attention, you know, it just might have turned into a different situation. And then the care I needed to get would have taken much longer to get. And that's scary. It is a little scary, but you know, now with my underlying condition, it also now throws in another challenge of, you know, how do I get back to work? Or do I continue to work from home? You know, and I have been working from home, and I'm so grateful that I have that opportunity because I love what I do. I love to, you know that our interpreters are out there working with our patients and our caregivers every day. But, you know, I don't want to walk away from it. I'm hoping I could, not I'm hoping, I will at some point be back at the hospital, but until, you know, things settle a little bit more for me and the COVID subsides a little bit more, I may not be able to get back right away because of the underlying condition factor. But we'll see. We'll see. I do plan on getting back there for sure.
And given your experience, certainly when we think about the Latino community who may have health issues besides COVID-19, this crisis is certainly complicating medical emergencies and situations for people beyond just being positive for COVID-19.
Well, I think this whole COVID experience has really brought out all of the inequities, you know, social inequities, academic inequities, who are the ones that, you know, are hurt the most during this COVID period when you don't have Wi-Fi in your home, right? How are you going to get that remote learning? You know, this really brought to the forefront many of the issues of poverty. And then, you know, many, I won't say many, but these students go to school to get a decent meal, right? And all of a sudden the schools are closed and, you know, moms and dads are working. That one important piece is now missing. So, you know, I'm so glad the schools came together and said, you know, we need to continue to provide meals. And so it's inequities at so many different levels, and health is definitely one of those big ones, but job opportunities, employment, education, safety, all of that has been so huge in so many different ways. And it has impacted our community, the Latino community, at almost every level. You know, just now not having a job, being furloughed, and maybe you don't have availability, you don't have the access to Medicaid. Now what do? You know, it's just, it's been a tough thing to see. It really has. And I'm glad at least our governor has, you know, come together to make sure that all people needing COVID care gets it, you know, regardless of their ability to pay, regardless of whether they're documented or not. So that has been an important piece too. Because, you know, I can't imagine the public health crisis it would cause had we not been able to see, you know, undocumented or uninsured or underinsured patients, right? So and they all fit together, don't they? They're all, one piece impacts another. The health inequity impacts the economic inequity, the impacts of, you know, the social inequity, the living situations. Yeah, all of it has come to the level.
Well, is there anything else you'd like to share with me about your experiences with COVID-19 that I haven't asked about?
I think one of the things I was very grateful for was to see the many Latino leaders come together nationally and locally to try to deal and address this issue that is impacting our communities. And I still to this day get data from Latino policy forums showing that we're still the ones with the highest number of COVID cases. And the fact that that this data is for us to be aware of this issue, and the many leaders trying to address the inequities, and not just for COVID. I think that it's got to be moving forward long term. We can't sit here and wait for the next pandemic or something else to come up. These inequities have really brought the unfairness of our living situation that many of the poor and vulnerable go through. And we just have to do a better job of making the playing field fair. COVID, was one of those really tough situations for not just families, not just for patients, but for communities and for us providers. As our rooms filled, the need to provide the service filled, and the need to get adequate employees there, because we also had people who were being impacted by COVID in their own homes, and this was just like a perfect storm in every way, and it was scary. And I think we're although it didn't get completely out of control, it could have, and it didn't. We have some good leaders and Latino leaders have stepped up to the plate to really say, look at what the data is telling us. This is not right. We need to do something about it. So I was glad to see a lot of that going on here in the Chicagoland area, of really taking charge of some of the impacts that this was having on our community, and working with the governor, and working with the state, and working locally with health department officials. And so there was more collaboration, if you will, among folks, but there needs to be more, and we know that. There's still a lot more work to do. And the question still becomes, how do we protect our Latino essential workers from contracting COVID the way they have? Because it's still occurring. I mean, our numbers are still high. So, we don't have the answers yet, but it's not something that's being ignored, that it does continue to be looked at. And I'm grateful even for this research you all are doing, because you can't put it away. That those days of history where things have been done by the Latino community and don't get acknowledged needs to stop, because we've been part of this history for hundreds of years, and we've been contributors, and we've been impacted, and we're as a part of the American society as anyone else. And so it's good you guys are doing this. You're archiving this and having it here available for others to see in the future.
Well, I really want to thank you, Mireya, for sharing your story with us and with future scholars and others to help them understand what it was like experiencing this moment in history, especially in the Latinx community. And we wish you all the best going forward.
Thank you so much, Dana. And just one little tiny thing I am going to add, the piece about interpreters versus translators, there is a difference, okay? And I probably should have started out in the beginning with this, but an interpreter is somebody who does the oral communication, converts one language into another orally in the spoken form, and a translator is the one who takes a written document and converts it from one language to another in writing.
Okay.
So that's the big difference that you might know somewhere. A translator versus an interpreter, and they both have two different sets of skills. And so what we really talk about is needing interpreters in a healthcare setting, and of course translation is there too, but it's with different skill sets.
Right. Okay, well, thank you for clarifying that.